Good afternoon. My name is Trinity Bivalacqua, and I'll be speaking with you today about the AUA SMSNA guideline statements regarding management of non-ischemic priapism. These are my disclosures. None are related to the guideline topic. As it relates to formation of the AUA SMSNA guideline panel, it was formed in 2018 and was developed in collaboration with the SMSNA. This initially was a joint effort that involved management of acute ischemic priapism and then non-ischemic priapism. Today, I will focus on guideline statements and recommendations related to non-ischemic priapism. Here are my panel members. I'd like to give a recognition to my Vice Chair, Nelson Bennett, as well as multiple members of the guideline panel that contribute greatly to its production. This is a significant update from a previous guideline that was published in 2003. It's been almost 20 years since a guideline has been produced on management of priapism. The scope of the guideline and index patient is as follows. I will not be speaking about the 2021 guideline, which already addressed acute ischemic priapism. Sections on non-ischemic priapism and recurrent ischemic priapism, otherwise known as stuttering priapism, is completed and under peer review. I will be presenting a preliminary draft of the guideline statements regarding non-ischemic priapism. The index patient that we'll be discussing today is an adult male presenting with a prolonged erection lasting greater than 4 hours. There have been significant additions to the guideline, which include a number of management options as well as surgical management of priapism. Today, we'll be speaking specifically about imaging, including ultrasound and MRI, and diagnosing ischemic versus non-ischemic priapism. We'll discuss conservative therapies as it relates to non-ischemic priapism, and also make the point about the enhanced data for patient counseling on risk of ED and surgical complications as it relates to management of non-ischemic priapism. By definition, non-ischemic priapism, or otherwise known as high flow or arterial priapism, is a persistent erection that may last hours to weeks. It is frequently recurrent in nature. Erections are nearly always non-painful, and cavernosal blood gas measurements are consistent with arterial blood. In contrast to acute ischemic priapism, the non-ischemic variant is not considered a medical emergency. Guideline statement number 1. In patients presenting with priapism, clinicians should complete a medical, sexual, and surgical history and perform a physical examination, including the genitalia and perineum. In the majority of cases of priapism, the differentiation of acute ischemic versus non-ischemic may be made using only the history and physical exam. This is a clinical principle. Here you can see in this table the different findings as it relates to ischemic versus non-ischemic priapism. On the right-hand side, non-ischemic priapism is considered a chronic, well-tolerated tumescence without full rigidity. This is usually the common presentation. It may be associated with perineal trauma, and there is no abnormal cavernous blood gas. It shows good oxygenated blood with the absence of deoxygenated blood. It is also not associated with intracavernosal vasoactive drug injections or pharmacotherapy for ED. Statement number 2, clinicians should obtain a corporal blood gas at the initial presentation of priapism. Blood gas testing is the most common diagnostic method of distinguishing acute ischemic versus non-ischemic priapism. This is a clinical principle. In the majority of cases, corporal blood gases should be obtained during the initial evaluation to diagnose the priapism subtype. Certain clinical situations where a blood gas may be omitted include recurrent priapism induced by in-office or at-home intracavernosal injection therapy, cases of recurrent ischemic priapism in which patients are presenting often to the emergency room with the same variant in history and physical, and the diagnosis and can be used in diagnosis and can be omitted when diagnosis is clear by history and examination. Statement number 3. Clinicians may utilize penile duplex Doppler ultrasound when the diagnosis of acute ischemic versus non-ischemic priapism is indeterminate. This is an expert opinion. Imaging should not be incorporated into the acute evaluation and management of priapism. An MRI is unlikely to have a role in the initial diagnostic and treatment phase of priapism. Imaging may be utilized in less clearly delineated cases to differentiate between acute ischemic versus non-ischemic priapism. Now moving to non-ischemic priapism as it relates to diagnosis. In a patient with diagnosed non-ischemic priapism, the clinician may consider a penile duplex Doppler ultrasound for assessment of fistula location and size. This is an expert opinion. Penile duplex Doppler ultrasound may be performed in a non-urgent fashion in a patient with non-ischemic priapism to help with screening of anatomical abnormalities and identification of cavernous arterial fistula or pseudoaneurysm location and size. And it can be used to monitor the location and size of a fistula or pseudoaneurysm. Ultrasonography should be performed in the lithotomy or frog leg position, scanning the perineum first and then along the entire shaft of the penis. Please note, a pharmacologically induced erection or full erection should be performed using ultrasonography. As it relates to management of non-ischemic priapism, patients should be counseled that non-ischemic priapism is not an medical or emergency, and they should be offered an initial period of observation. This is an expert opinion. The panel felt that non-ischemic priapism is considered a potential chronic condition and does not warrant urgent surgical or medical management. Non-ischemic priapism is not a medical emergency. In contrast to ischemic priapism, non-ischemic priapism results in an erection with fully oxygenated corporal blood, and thus no immediate erectile tissue damage occurs. Therefore, you can have a trial of observation to determine if the fistula or pseudoaneurysm may close on its own. All patients should undergo a period of at-home observation. The panel felt 4 weeks was sufficient to define if the fistula will close spontaneously, resulting in penile detumescence. In cases where the fistula is unchanged, as determined by a Doppler ultrasound of the fetus, and/or where the patient's bother is significant, intervention may be considered. As it relates to management of non-ischemic priapism, in patients with non-ischemic priapism who have failed a trial of observation and who wish to be treated, embolization should be offered as the first-line therapy. This is grade C level of evidence, a conditional recommendation. Prior to consideration for embolization, the fistula should be readily visible on duplex Doppler ultrasonography. Ultrasound should be performed in the erect state, and both the penile shaft and perineum should be scanned. Angiogram is utilized to perform the embolization after it has been identified by ultrasound. In the systematic review that was used to come up with our guideline statements, 38 studies assessed the outcomes of embolization with greater than 250 patients studied. Embolization had a documented 85% success rate as defined by penile detumescence, and more than 80% of men after embolization retained functional erections. With regard to the technique of embolization, both resorbable gel foam or autologous blood clot and non-resorbable microcurls of PVA materials can be used. Similar rates of detumescence, preservation of functional erections, and recurrence were found between studies assessing both resorbable and non-resorbable agents. PVA particle use was associated with the best erectile function recovery, and autologous blood clot had the highest rates of recurrence of the fistula. Technical success by the interventional radiologist occurred in 96 to 100% of the cases studied. Detumescence was present in 70 to 87% with an overall 80% detumescence rate. Erectile dysfunction after embolization occurred in 7 to 19% of patients, and recurrence rates range between 13 to 29% with an overall 20% likelihood of recurrence in patients who underwent embolization with either a absorbable or non-absorbable agent. As it relates to management, the clinician should perform repeat embolization in patients with diagnosed non-ischemic priapism who are refractory to embolization. Grade C recommendation, moderate recommendation. Data suggests that this is more likely to be effective and safer than an attempt at surgical ligation. Given the lack of experience in the latter approach for most urologists and the poor data supporting surgical ligation, The panel and data would support the repeat embolization in patients that have failed first line therapy with embolization, period. Moving on to counseling, the data and systematic review suggests that patients should be informed that embolization carries a risk of erectile dysfunction, recurrence, and failure to correct non-ischemic priapism. The reported erectile dysfunction rates and recurrence rates should be discussed with patients prior to embolization, and patients should be counseled as to the success of each of an absorbable or non-absorbable agent. In summary, non-ischemic priapism is not a medical emergency, and a trial of observation should be considered. Penile duplex Doppler ultrasound identification of the fistula with embolization following is most effective irrespective of the coil type. Consider re-embolization for patients that recur prior to any surgical approach, and embolization can cause side effects including erectile dysfunction and failure to cure with refractory cases. Thank you very much for taking the time to listen